What is endometriosis? How to recognize the symptoms of endometriosis? What are some possible treatment options that are effective for the management of the symptoms of endometriosis? And kind of what is the difference between how an expert would manage the disease state compared to a general OB-GYN?
All right, welcome again to VNEW Health, powered by Arms Medical. I'm Robert Greer, and today we're talking endometriosis. So if you think about the word itself, endo, which is within, mitra is uterus, and osis is an abnormal condition. So we're going to do a deep dive with Dr. Matthew Palmer, fellowship trained and minimally invasive OB-GYN in Maple Grove, Minnesota. Dr. Palmer, welcome to the program.
Thank you, Rob.
So, you know, it's a word that women are familiar with, but then if you really dive into it, they're going to go, well, I heard about it. I had a friend who had it, but I don't really know what it is. How do you explain it to the ladies that come into your clinic wanting to know about this topic?
Well, I think this is something that's gotten more and more traction in the last several years because of social media and just, the broadening of the conversation around the topic in general. Um, there's a lot of people that blog and write and, post about this condition and their symptoms, and then that generates a lot of conversation, a lot of buzz. Endometriosis affects about 1 in 10 women. And it is a condition that is primarily associated with pain and can have other symptoms. And really the important point is sort of an assessment of and development of a line of questioning to understand those symptoms. And if somebody really has it or not, you have to prove it typically with a surgical diagnosis because it can be hard to pick up other ways. And so I'm always trying to understand people's symptoms very completely, history and symptoms, and it helps me kind of formulate a decision as to whether or not I think they have endometriosis. Essentially,
Because normally they're going to walk in, right, and they're going to say they've got some pain. That's like the number one component, and then they're gonna talk about their menstrual cycle and when that pain starts to flare or be higher or lower.
so endometriosis is basically characterized by the presence of endometrial-like tissue that can grow outside the uterus. And so it is when these tissue areas are biopsied, they will come back pathologically similar to the endometrium, and that includes certain types of cells, like they're called glands and stroma, and that would be what a pathologist is looking for. What I'm looking for are loosely defined as lesions or growths or inflammatory areas. They look like little areas that could be red, brown, black, and they grow, these little structures, these little lesions grow into tissues like, for instance, under the ovaries or into the deep pelvis, kind of between the rectal and the uterine area, or near the bladder or into the pelvic sidewalls. Basically anywhere in the abdominal cavity. They can grow outside the abdominal cavity. It's more rare, but I do fairly frequently see endometriosis of the diaphragm or of the bowel, of the upper abdominal sidewalls. And so part of my survey is to survey everywhere to make sure I don't miss anything when I'm doing surgery for these patients.
So when you spoke, you mentioned biopsy. What's involved in that? Is that taking them, something you do in your clinic, or is that going back to the OR?
So, when I talk with the patient about their symptoms and we kind of and I can delve a little bit more into what those are, but um, once I'm feeling confident that a patient has endometriosis based on their symptoms, potentially an ultrasound or an MRI, a physical exam, we often make the decision to go to surgery, which is usually a laparoscopic surgery, typically a same-day surgery that involves small puncture incisions where we're working inside the abdomen through a little port or a little cannula that goes into the abdomen with long instruments that go down those ports, and then the surgical interface being uh, on a screen where I'm seeing the insides of the abdomen on a screen and working with different tools. Typically, in my hands, it's a robotic laparoscopic approach with the Da Vinci, and allowing what that allows is very precise dissection and handling of tissues carefully, and also 3D high definition vision to really see around all the structures. So when we're talking about biopsy or pathology, we're talking about going in surgically and surveying completely the abdominal and pelvic cavity, and then identifying areas of dysfunction, of lesions, of areas where the ovary might be stuck, or where I'm seeing a, a raised, tightened, red, irritated looking area, and then excising that out. And so what that involves is picking up the tissue and carefully kind of using electrocautery and the tools that I have to my disposal to kind of cut around those lesions. And then carefully, controlling bleeding and protecting any unaffected tissue around it with careful, precision, and then sending those specimens off to the lab, essentially, where they're created into slides and then evaluated by pathologists.
Are you waiting for an immediate diagnosis, or you just know that those lesions should not be there? We're going to remove them. And in addition, we're also going to do pathology.
Correct. Yeah, and what you said the second time. So, with the experience of seeing and doing a lot of these surgeries, I've been able to develop a good eye for seeing lesions and trying to not miss anything. And so I think one of the things that differentiates, expert excision-based surgery from not is just the volume of um, cases that someone has done, and like how readily they're able to recognize everything they need to recognize. And so typically when I come out of the surgery, I'll know what stage of endometriosis it is just by looking at it and what I've had to do surgically. And then we'll just get kind of confirmatory feedback from the pathology report, but it won't necessarily most of the time change, the stage or what I've had to do or anything like that.
So in someone developing this condition, what's the age group that you normally see it?
So, typically these lesions, I think it's easy for people to conceptualize the menstrual period and the menstrual cycle. And typically when young women are starting their period, they're maybe around 11, 12, 13 years old sometimes. And when that happens, there's a building up and a shedding of the endometrium that's a cyclic pattern, okay, the lining of the uterus. So these tissues that respond like that tissue also similarly do that and respond to the hormonal cycle of estrogen and progesterone that the ovaries are producing. And so there's different theories about why and how and who gets endo, but probably the best understanding of this disease state is more of an autoimmune type problem. It's an inflammatory condition that can be systemic in its effect. It can affect a lot of different people in different ways systemically. And then also, locally to the areas that the tissues are impacting. And so, um, you know, we're kind of seeing, that you're going to have, sort of um, an area where the lesion will grow in and will impact that direct spot. Like maybe let's say it's under the ovary and you can get some ovarian adhesions where maybe that left ovary or something is stuck to the pelvic sidewall from this inflammatory lesion, and a patient will notice, mid-cycle pain and pain with ovulation and things like that. That type of thing tends to become progressive over time. So as this is initially occurring, people start to notice symptoms when they're early in their menstrual years, early teens. People, oftentimes young girls present with super painful periods, very heavy periods, irregular, out of character pain to their friends, let's say, to someone else around them. it's common to have cramps, but it's not common to be vomiting during your period, to be curled up on the bathroom floor, can't move, to be missing school, to not want to hang out with your friends because you're just down for the count. Those kind of things are pretty severe. And um, so I often, unfortunately, see a lot of patients' symptoms get normalized and get minimized and diminished, and sort of people feel like those around them. It can be an isolating disease because people don't understand. Oftentimes, oh, that's just normal. It's normal to have bad periods. You got to suck it up. I hear a lot of different things from people where they feel like they get told that they just have to live with it and this is normal.
Part of being a woman.
Part of being a woman. Yep.
Hey, you gotta suck it up. It's gonna happen once a month, but they're really, what you're pointing out, it is above and beyond this normal menstrual pain that women experience, to the point where they're an outlier. So what's the youngest that you treat in this?
I mean, I've done surgery on 14-year-olds before. I try not to operate that young if we can help it. I'm more in favor of sort of medical, usually hormonal therapeutic management for a time, to see how people respond to that, because there is the understanding, I think, best placed on endometriosis management is that it's multifactorial and multidisciplinary. So surgery is one piece of the puzzle, and as I've gotten deeper and deeper into the management of this disease state and seen the many hundreds of people that I've seen, I've learned that those that do the best have a multifaceted action plan. And so, I have certain things that I talk with patients about as we're talking about long-term management, maintenance, future steps for best practice to feel the best. And some of those things could include hormonal therapies, trying to find a supplemental hormone like a birth control type, like an IUD or a ring, or different things that they can do that kind of stabilizes their hormones, normalizes them to that product that they're taking, and kind of steady states their symptoms. Now, that's not going to cure endo, but it can help symptoms.
It'll help reduce the pain associated with it. What do you find to be the the most effective non-surgical approach? Like, where would you start first, right? You've gotta kinda look at their symptoms, look at their age, but what do you find yourself leaning into more often from a non-surgical, and then, of course, get progressively more aggressive?
I think, a hormonal approach, generally speaking, that helps a patient have minimal side effects, but that can actually suppress their menstrual periods. So we're generally aiming for a steady state therapeutic option that's gonna allow them to skip their monthly periods. And that can be done in a number of different ways, through kind of skipping the placebo row of a birth control pack, or kind of just think different options that we would discuss, but ultimately when we think about the the hormonal approach, it's actually sort of mimicking a pseudo pregnancy state. And so when someone's pregnant and they have a placenta that's producing progesterone and estrogen to support the development of that pregnancy and that baby, their hormone levels are very stable during that time frame. And so often, actually, people that have endometriosis feel good when they're pregnant. They have an ablation.
The positive side effects of the pregnancy is that this doesn't flare like it normally would.
And so we're kind of trying to mimic that sometimes in hormone therapeutic options. And, people often resonate with the idea of having really high estrogen levels. And so that's a common feature of endometriosis. And so that a lot of people that have endo also have menstrual headaches, they have breast tenderness, they have nausea, they have a lot of heightened mood symptoms related to their, you know, PMS type symptoms that are severe. And so a lot of these things coincide with high fluctuating estrogen levels. So if we can mitigate some of that by stabilizing the hormonal approach with a hormonal product, it's going to help their symptoms. So that's probably my go-to, is to try to find a tolerable approach. It could be a progesterone only, low dose estrogen progestin combination, an IUD, a NuvaRing. Those are kind of my more common ones that I go with. And then we find a solution that's going to be accessible to a patient, affordable. Can they handle remembering to take it? All these kind of things we have to kind of consider depending on the patient's age and life factors and such.
To figure out what device is gonna help them reach that maintain that steady state. Now from the hormonal side of things, diet, exercise, food, are there things that you would direct your patients to try to, because you talked about inflammation, inflammatory foods. How do you coach them or counsel them in that space?
So we really believe strongly in a multidisciplinary approach to management, that it can include functional medicine and dietary considerations, including supplements and low inflammatory eating strategies. A lot of people use elimination diet type approaches to see what their triggers are. The low FODMAP diet or keto, or different things that people can try that seem to kind of a lot of people have triggers that are related to common things. So a lot of people have dairy triggers, sugar triggers, alcohol triggers, gluten triggers. And so sometimes navigating through those issues can help people's symptoms a lot. It's one of the pie pieces of the puzzle that we're looking at to try to help have a fully holistic approach of management. I have a dietitian that I work with very closely, that I refer the majority of my endometriosis patients to, who will sit down with them, help understand their intake, their supplement regimens, and try to help get them onto an anti-inflammatory strategy that works best for them. We also, believe strongly in ancillary therapies for chronic pelvic pain. So, what happens with endometriosis is that people develop chronic pain that becomes a secondary entity to the endometriosis itself. They develop musculoskeletal dysfunction, where their pelvic floor gets tight and hypertonic and reactive, and they become more symptomatic with things like painful intercourse, painful bowel movements, just always tense and tight. They have a hard time sitting for long periods of time, or exercising or things like that. And really, that's a secondary problem to repetitive cyclic pain patterns. So when that develops, we want to understand there's people that are very specifically trained and experienced in pelvic floor therapy, pelvic floor physical therapy. And so we have a couple, excellent pelvic PTs in our practice, and I have a lot of other referral sources around the Twin Cities metro area and regionally, where I primarily practice, where I send patients for that type of therapy. And we often talk about that as an instrumental part of their maintenance program for long-term success.
Yeah, because they've gone through this chronic pain with endometriosis. Now it's affecting their entire pelvic floor, which then is they're leading, if they have partners, quality of life issues, and it's just this cascade where we go, okay, we got to start walking this back, because we might be able to address the endometriosis, but now we have all these side issues that are going on, and which is great that your practice center of excellence in the space of endometriosis. How did you get you know passionate about this particular condition? What said, hey, I want to master this?
Well, I mean, a lot of it comes down to just lack of access for patients and lack of available specialists in this area. There's just so many people out there that, like I said before, get dismissed or get told there's really nothing else we can do. And I've just found that there is a better way. And over the course of time, through it started out for me with extra surgical training. So when I was in my residency program, coming out of med school, as all OB-GYN residents do, you have a limited amount of time in the OR, really. I mean, comparatively to like our general surgery or orthopedic or other colleagues, because we're spending a lot of time mastering other things, delivering babies and managing high risk pregnancies. And, we have a rotation with cancer, female cancers. And ultimately, at the end of the day, you're kind of dwindled down to really a couple years probably of surgical experience compared to 5 or more for other specialists. And what I found coming out of and through that process is that I knew there was kind of a bigger world out there of more advanced surgical care that I wanted to be able to provide to my patients. And I always enjoyed the surgery. I enjoyed the technicalities and the kind of the before and after, the benefit of helping someone very tangibly. And so I did, after my residency, I did an extra 2 years of minimally invasive surgical fellowship training that was focused primarily on laparoscopic surgery, somewhat hysteroscopic, and, a lot of robotic. But through the course of that 2 years, I did around 500 surgeries as a primary surgeon, as a fellow at a big training program in Detroit. And
Off to Henry Ford, right?
Henry Ford, yep. Shout out to Henry Ford. I had a great surgical experience there.
No shortage of patients,
Yes. And so that
24/7.
that was the launching pad really for, like, seeing a lot of pathology and kind of, I think for me with endometriosis, I've always say, like, the more that you do, the more that you do, so you develop a comfort level with, certain types of anatomy, things that are difficult working around the ureters or dissecting the vessels of the colon or, the posterior cul-de-sac. And once that becomes for me, it was like, okay, I started to get comfortable and I started to be, okay, no, that I saw that thing. That was kind of crazy. That was a little hard to dissect, but I got through it. I learned something from that. And so just, over the course of time, now 12 years in, I mean, I've done, I think, like 1,700 robotic cases. And just you just see a lot of things, and so I see the results that I get. I see the outcomes that people have. I see the lives change, the quality of life benefits, and a lot of word of mouth, happens with people on, like I said, internet and discussions boards and Facebook and Instagram and things, and then that just leads to more people trying to seek out a different type of care for this problem. They know they have it. Most of my patients come to me having had prior surgery, by and large. So they're there for a second or a third opinion. They were told, oh, we couldn't get that spot out. It was too close to your bladder, or whatever they're told. You have too much, or it's too hard, or we have to open you, or all these different things that people hear.
We got most of it.
Yeah. And they're kinda like, I read that there's another way out there. Can what do you do?" So
So of the people that so you mentioned, okay, so the a lot of people are secondary surgeries that you see, and then at the same time, you know, after someone goes through the procedure with you, what's the risk of developing it again, and then what's that timeline look like?
so there's reasonable data to support the idea that excision-based surgery conveys a statistically significant reduced risk of recurrent endo. So, it's hard to put a true, like, percentage on it, but I typically tell my patients anecdotally that there's about a 70% chance they won't have to have recurrent surgery for their disease if we get in there, identify it, and fully remove it. And that's variable, depends on what kind of suppression they're on afterwards, if they're having kids, if, how advanced it was. There's different things that alter that variability, but for the most part, if I do see recurrence and we do end up deciding to go back to surgery, it's usually around the 5-year mark, often, something like that. Um, and I see people from all these different phases and facets of their life, and it's important to know for patients that every person's journey, although you have similarities to others, it's a unique story for you. And so I'm very interested in developing a plan that's going to work individually for that specific person. Are they trying to conceive? Have they been trying to conceive? Have they had recurrent miscarriages? Are they done having babies and they want their uterus out? Are they, whatever it might be. I mean, you have to kind of individualize therapy and not all none of the surgeries are exactly the same, and so you have to kind of decide and understand people's short-term, long-term goals, um, how aggressive to be based on, someone's got a big ovarian cyst that's filled with endometriosis. If they're 20, that's gonna look and they wanna have kids, that's gonna look different than the 40-year-old that's had 3 kids, and now we're feeling pretty comfortable about taking that ovary out, and, there's just a lot of variability to what we're recommending, counseling, imagining with the patient depending on their situation, so
No, all valid points, and I think, step 1 is to book an appointment with you and comes you in.
and I'm a big, I want a lot of information, I gather a lot of information from people, so, I the way my office protocol works is I have a pretty detailed questionnaire that I send people when they want to book an appointment. It's like 18 pages long and it's very detailed on like everything that's related to their history of their pain. It's bladder history, bowel history, surgical history, sexual history, how it affects their work, their life, their pain, their depression, their all, lots of like I try to gather as much information as I can so that when I walk into a room, I've got all their records from what they've had done and I've got that detailed questionnaire and I can say, "Hey, Mrs. Smith, like nice to meet you. I learned all this information about you from all the records and all the documentation and the story you told in your questionnaire. And I have that baseline now. Now let's talk about what's going on right now, and then it's just like it makes the conversation so much easier and more in depth and informed than just walking in saying, "Hi, ma'am, what brings you in today?" 'Cause
It's way too long. And when, you gotta, and which is great because you do in essence, a pre-read
yes,
so that "Hey, this is where I'm gonna start, and if I gotta refer back a little bit because you said this, I circled it, I have a question, but now and let's jump into why you're sitting in my office today." And that's a great approach. So if you do have an opportunity to see Dr. Palmer, make sure you fill out the questionnaire, alright?
please, yes.
Please, it helps. We're switch gears a little bit because I was thinking, if I'm a patient, what would be the things that I would be asking you about? So I jotted down some questions. So I'm gonna ask you some questions, you can answer them, and then you tell me which questions I missed, alright? So, how does it impact my fertility? And am I still gonna be able to have kids?
So probably my tagline with that is most people that have endometriosis can have kids, but one of the most common things that causes infertility is endometriosis. So it can affect people in that way. And endometriosis can be multifactorial in how it causes infertility. So it can cause structural damage to the reproductive organs through the adhesions, through the inflammatory lesions. It can cause, like a kind of a distortion of the fallopian tubes at the ends. It can kind of block the tubes, or it can cause them to be stuck to the ovaries, and that can affect just the natural process of egg being released from ovary into tube. You know, just structurally, it can be a problem. But then it's also the inflammation that endometriosis causes. So sometimes everything structurally looks normal, but if there's a lot of cyclic repetitive inflammatory happening, you can see kind of a decreased motility through the fallopian tubes or a decreased implantation, probability. And so, we have to kind of look at endometriosis as one independent variable in infertility and make sure we're not missing something, So, um, a thorough workup with depending on where a patient's at, how long they've tried, have they been able to become pregnant before, are they with a new partner? I mean, there's a lot of things there's a lot of things you have to consider, but definitely endometriosis can and does affect fertility. And, the idea behind one of the ideas behind surgery primarily, number one is symptom management, but number two is fertility optimization. So I'm always asking questions around fertility and childbearing desires and goals and timeline and things like that when we're considering surgery, because what we want to do is to go in there and try to normalize as much as possible so that things structurally, functionally, and physiologically look as healthy as possible for the potential for pregnancy.
And to be able to remove those cells and that tissue, and which, you doing it robotically, it's a game changer. Would you not say,
I would.
compared to from the
It's
laparoscopic of what were you doing at Henry Ford, and then the introduction of robotic procedures, because you probably, you have to do both, and so now it gives women a lot more of a fighting chance to uh, get pregnant if they so desire.
Yep, I think there's a lot of people that are very, very skilled laparoscopists with straight sticks and the normal long, tools that people use, and um, I would never want to diminish the experts that do it in that way because there's a lot of people that do really excellent minimally invasive excisional based surgery with laparoscopy. But in my hands, and many people have discovered and learned that robotics particularly can be a really enabling tool because of the type of dexterity that we have with working around corners and wristed 3D motion, high definition vision. And so really the idea behind the tool, it's just another tool. Robotics is another tool that you use. But it really depends on the surgeon, what they're comfortable with, how experienced they are with a particular technology, and, what kind of outcomes can they achieve based on their skill level with whatever. Like, I would not be nearly as accomplished of a straight stick laparoscopy surgeon right now as I am robotically because I've done so many hundreds more robotics that I'm just better at it.
It's a more natural approach for you, and better for your patients, which is always, align the skill set to, well, what their outcome is trying to gather. Um, so from a pain perspective, is it non-steroidals? Do you go anymore? Do you look at other type of pills, or how can I control my pain better?
My perspective is we're trying to avoid long-term opiate therapy. I think we know that there's a lot of potential harm, with opioids and addiction and, the need to increase utilization to get the effect and things like that. It's kind of a long-term losing proposition, unfortunately, when someone has to rely on opioid therapy for chronic pelvic pain. So I try to strategize around not using opioids. However, it is sometimes necessary occasionally. I'm not 100% no on that, but more what I'm trying to do is to find a best acting anti-inflammatory for the patient. So I'm a big fan of using long acting, slow release anti-inflammatory NSAIDs like Celebrex and Meloxicam or Mobic, um, sometimes Toradol orally. But those are medications that you can typically take like once a day to achieve a long lasting effect compared to having to take like, 4 or 5 ibuprofen, 3 to 4 times a day. And it's much more easy on the GI system and less harmful on the kidneys. And so that tends to be one area that I always look at as the NSAIDs and the long acting NSAIDs. Um, we definitely do a lot of work with muscle relaxers. So I will oftentimes prescribe oral muscle relaxers for patients that have a really tight pelvic floor or radiating pain down their legs. My primary tool actually for that is a transvaginal suppository with muscle relaxer in it. So we'll use a compounded medication that has a little bit of baclofen and some Valium in it. And there's other cocktails that people use that have different things, but that's the one I do. And basically, I have a patient insert that into the vagina at night before bed, and that actually absorbs into their tissues and creates an excellent relaxing, muscle relaxing effect. And a lot of people tell me that's the most impactful thing on their pain is that type of therapy. We'll occasionally use some neurologically, neuroleptic type medications like gabapentin or Lyrica, some of the things that are used for like diabetic uh, neuropathy and things like that can also be helpful for patients with chronic pain. So it's not a one size fits all. I navigate through the conversation and I try to insert ideas to those ends where it seems to make sense for each patient.
No, absolutely, and thank you for sharing your approach. If you so if you just put me on hormone therapy, what effects should I be expecting? What's gonna, what are the outcomes that are gonna look like it?
It's a little bit different for everybody, and so you have to kind of find what each person is going to tolerate. I find there's just a wide variance in what people tolerate. And so oftentimes if it's not well tolerated, people can have mood disruption, particularly severe depression, or, even like suicidal ideation and things when it's a really bad, fit for them. A lot of people can feel flat and, like loss of energy, loss of libido, like
Just
just
blah.
kind of blah. Yep. Yep. Similar to being on like a antidepressant or something like that. Um, People can develop, problems with like spotting, cramping, things like that, sometimes with the wrong fit for them. They can develop weight gain. A lot of people can develop like menstrual headaches, sometimes, and nausea. So some of the things that people present with that have endometriosis, they also can have when you put them on some kind of a hormonal approach. So oftentimes it's trial and error. It's kind of me making my best guess as to what I think is going to help them, and then we give it time to let that play out, maybe a month or 2 or 3 to kind of see how they're doing. We follow up, we discuss, we modify as needed. Sometimes we lower the dose, we change altogether, whatever it might be. But um, it's not just like, okay, here's some birth control pills, have a nice day. It's an ongoing conversation, regular check-ins. I typically probably would see an average endometriosis patient 2 to 3 times a year, roughly, for different, like an annual or a check-in visit or a med check or, you know, a problem visit, an ultrasound, whatever. I mean, there's sort of regular follow-up. And so that's one of the things that I have enjoyed about this specialty in general is continuity of care and regular follow-up and like kind of walking with the patient through the journey of their life. It's one of the most rewarding things for me of all time is when I can see a patient when they're younger, know they have significant issues with endo and pain and help them do a surgery, whatever, and then they are able to conceive and have a baby. And then I've gotten to deliver some
You
babies,
get to deliver to the baby then,
you
and
know,
you're like, "Okay."
uh, help to someone with earlier in their life with surgery or whatever. So, that kind of thing, just the whole journey, the whole story is just awesome for me, and I love helping people in that way. So
We thank you for that because there's not enough specialists like yourself, and if you listen to the complexity, in our managed care environment, you're always on the clock, and, they want you they wanna be, one and done in 15 minutes, and we'll see you next year, and it's just not the case, and so, it takes a lot more out of your time and out of your practice, so I know the women of Minnesota thank you, and of course, probably some surrounding areas in Wisconsin and Iowa and North Dakota and South Dakota, and maybe some people down from Canada that come and see you in your practice. Um, final question in this space of what's the red flag? How do if I'm listening to this podcast, I'm saying, well, this could be me. What are some red flags that go, I think you need to go see a specialist, right? We kind of alluded to a few of them at the beginning, but how would you summarize it to someone that hasn't ever been officially diagnosed with endometriosis?
I would say progressive symptoms that seem to be existing outside of just menstrual symptoms alone. It's more than just painful periods. It's pain that's very deep, pain that radiates, pain that most people should not have be having pain with intercourse. Okay, that's something's wrong. That's not a common. That's not good. That's not something that just everybody has. That's something there is causing that. Um, you know, pain pain with bowel movements, severe bowel changes like severe constipation or severe diarrhea with their periods or preceding their periods, blood in your stools, blood in your urine, severe pain or irritation with your bladder during your menstrual period or premenses. These are all indicators that there's something inflammatory in there that's affecting those surrounding organs that is probably not going to, probably needs to be dealt with in a more comprehensive way than, just putting you on a pill or even, a more conservative surgical approach of just kind of cauterization of lesions without excision. That's a whole nother topic that we could get into, but ultimately it's basically trying to when you people have deeply infiltrative symptoms like I'm describing, they're the ones that are going to benefit most from surgical excision and expert excision.
Thank you for that. And so for all of our listeners out there, if this episode resonates with you, make sure you like the like sign and share it with your friends. Share it with someone who could benefit from this topic. And Dr. Palmer, as always, we thank you for being on the show. And another extended thanks for taking care of my mom. I think you say you saw her today.
I did see your mom today. She's doing great.
There
So
we go.
I'm happy
So
to care for her. Thanks for letting me do that.
absolutely, a pleasure with that. And you have a good rest of your week.
Okay, you too, Rob. Thanks.
Bye bye.